The next speaker is going to talk about women's health, which is a big issue. Dr. Brockmeyer is beginning, and she will be joined by her colleague, Dr. Barrie. Thank you.
Is that okay? All right. Make sure I got everything going. All right. Good morning. My name is Dr. Amy Brockmeyer. I'm a gynecologic oncologist at Virginia Mason. For those of you familiar, gynecologic oncology manages ovarian cancer, endometrial cancer, cervix cancer, complex pelvic surgery related to cancer of other types, colon cancer, et cetera. Genetic disorders related that can increase the risk of cancer here. And Dr. Barrie and I practice the full scope of GYN oncology. So diagnosis, surgery, chemotherapy, and when needed, things like hospice, end of life. So if you have patients who you have concerns about those things, we're happy to have you reach out. I want to talk about something that has changed over the past couple of decades for the better, and that's cervical cancer screening and prevention. At Virginia Mason, I'm very lucky to work with my partner, who you'll meet shortly, another GYN oncologist. We also have 3 fellowship-trained minimally invasive gynecologists, so folks who manage chronic pelvic pain, endometriosis, fibroids. The vast majority of our practice, the 5 of us, is minimally invasive. For patients, that means recovery. It is something beyond what I would have imagined when I was in residency, patients coming for surgery, going home the same day, for many cases, even cancer surgeries. For patients who travel a long distance, that could mean we could meet patients by video visit, complete part or all of a consultation remotely, and then have patients travel to Seattle for a surgery and potentially go home the same day. I have some patients from this region who are very pleased then to follow up with their local physicians like you guys who they trust and know. We also have a huge cadre of excellent nurse practitioners. I'll include my email address if you have questions about whether or not patients may benefit from either seeing our gynecologic oncology team or our minimally invasive gynecology team for people that you may see in your clinic. All of our emails are first dot last name at VMFH, Virginia Mason, FranciscanHealth.org, and we welcome you to reach out if you have questions. All right, so the hope of this talk is to remind you why screening works, understand the new vaccination recommendations, and why there has been a recent change from the American Society of Colposcopy and Cervical Pathology regarding the guidelines of how to manage pap smears and how to use them in the frequency, as well as how to incorporate these guidelines into your practice. Some of the recommendations in the past have been extremely complex, and incorporating them into your day-to-day clinic has been difficult. And some of the changes have made this much simpler, and hopefully will benefit our patients. It also is important for us to recognize that in this area where we have excellent screening and excellent prevention, that one of the biggest hurdles to getting improvement in patients getting cervical cancer is making sure we're able to get these tools to our patients. Cervical cancer incidence is still is improving, but still quite high, with about 4,200 deaths in the US in 2022. Luckily, many patients who have cancer or cervical precancer were able to identify and treat and prevent this issue. As a reminder, cervix cancer is not only caused by HPV, it requires a long-standing HPV infection. I always tell my patients that anyone who's had sex with someone who's had sex with someone else has been exposed to HPV. It's a ubiquitous virus, and vaccines can be very beneficial in preventing a long-term infection, which is a necessary cause for cancer. As you can see on the top where it notes normal and CIN2 to CIN3, or cervical intraepithelial neoplasia precancer, there's a bidirectional arrow between normal and CIN2, CIN3. What we know is that in some patients, mostly in patients who are young, which by this body is patients less than age 26, we can see resolution of CIN2 without intervention, just with time and an immune response. This is huge. I remember in residency in the early 2000s, we had colposcopy clinics filled with people in their late teens, early 20s. We did colposcopies and leaps and exams so frequently. And now, and I'll remind you later, that we don't even do screening tests in those patients, because when they have HPV-related infection and even cervical changes, this bidirectional arrow shows us that they can clear those HPV infections and those changes without our intervening. That's been a huge improvement for our patients and has allowed us to step back in terms of how we care for those patients. If you identify a CIN2 or CIN3 lesion, those things are precancerous. There are some exceptions in the CIN2 arena, but in most patients, CIN3 or high-grade cervical dysplasia requires treatment, and in the vast majority of the cases, we can prevent progression to cancer. If you'll note on the bottom, persistent infection can be anywhere from 1 to 10 years. This gives us a huge lead time to be able to utilize our screening tests. This points out, again, the two targets that we have to prevent cervical precancer and therefore cervical cancer. Number one, HPV vaccination. Vaccination prevents over 90% of cancers caused by HPV. And early detection and treatment of precancer, so testing pap smears, cervical cytology, the way cells look under the microscope, as well as the presence of not only HPV, but certain strains of HPV that are very high risk, can help us to identify and pinpoint which patients may be at most risk, so we can focus our treatment, our attention on those patients, and leave people who have low risk HPV or no HPV alone. All right, you all know that HPV cancers are preventable. I'm focusing on cervical cancer and cervical precancer, but oropharyngeal cancer, anal cancer, vulvar, vaginal, and penile cancer are all also caused by HPV. It's important as we talk about who we vaccinate, both males and females, that this will have a benefit for all of those populations. As a reminder, routine vaccination is recommended at age 11 to 12 and can be started by age 9. If you complete the vaccination by age 13, patients only need 2 vaccines. In those in the catch-up years, age 13 to 26, 3 are needed as a result of the immune response. There is a recommendation now that there may be some benefit for patients up to age 45. All of the practitioners, physicians, nurse practitioners in my group who are eligible have been vaccinated against HPV now. The proof is in the pudding. We've showed that we trust this vaccine. It's safe. We've gotten it ourselves. We are starting to see predictions from some of the countries who have had excellent uptake of HPV vaccination that we're going to eliminate cervical cancers. In Australia, in England, we're seeing huge uptake in the vaccination, and over time, we're going to stop seeing cervical cancer. The World Health Organization recognizes the benefit that we can have with this vaccination in eliminating this disease. Their goal by 2030 is what's called the 90-70-90 targets. They plan to have 90% of girls fully vaccinated with the HPV vaccine by the age of 15, 70% of women screened with a high-performance test, that's HPV testing, as well as evaluation by the age of 45. Those 2 ages are chosen taking advantage of the fact that a long-term HPV infection after the mid-20s is a really important predictor and risk factor for cancer. And then 90% of women with precancer treated and 90% of women with invasive cancer managed. And we're on track to meet those targets. Here are my 2 little humans. These are both my sons. They have, the older one has completed his HPV vaccination, and the younger one has started his HPV vaccination series. Again, these are hugely safe vaccines. They're recommended for both boys and girls. My sons are vaccinated. The World Health Organization reminds us that nobody should die from cervical cancer. We have the tools available to prevent this disease, and we have the screening tools to be able to identify it early in those patients who do have precancer, to allow patients to have long, healthy lives and without having effect on their fertility. All right, patients trust you. Patients will get vaccinated if you recommend that they get vaccinated. Maybe not the first time. Maybe you have to fight them a little bit. Maybe you have to remind them every so often. But patients do trust their clinicians. And studies have shown that if we continue to recommend them to patients and reassure them that they are safe, we have overwhelming data regarding the safety of these vaccines that they will listen. Some of the perceived barriers patients have can be financial, insurance coverage, can be that they're non-mandatory. You have to travel at least twice or 3 times to the doctor. That can be a barrier, as you guys know. There are some people who have the false thought that if you vaccinate children against this vaccine, it's like a free pass for them to have sex as much as with whoever they want. And that data just doesn't bear out. And then a vaccine is a shot. People don't love shots. They have fear of pain. They've had a negative vaccine experience. We can really change people's mind about this just with us being trusted parts of their healthcare team and reminding them that this can decrease the risk of issues, not only for them, but for their partners going forward. All right, so in vaccination rates in Washington, the numbers on top show that us in Washington are doing about the same as the rest of the United States. The bars on the bottom, the top 2 bars are females. We're doing a little bit better than the US at about 65% of vaccination for females, and a little bit worse than the United States and Washington at about 53%. So we have a lot of opportunity here to get this vaccination to our patients. All right, screening recommendations. Who gets screened and how often? This is also something that has changed. It has been something I sometimes get pushback from patients about. They think they need to pap smear every year. That goes along with their pelvic examination. Patients who have had dysplasia and have been told that they need yearly pap smears sometimes will push back about this or will miss their routine screening. We all miss like our dental appointment by 6 months or a year. So maybe if they think they only have to come back every 3 years, that might get spread out to 3, 4, 5 years. So this is important to understand so we can keep people on track. All right, so we do not screen women aged less than 21 years of age. Those colposcopy clinics where we have teenagers filling our waiting rooms, filling our exam rooms, those days are over. We know that the vast majority of the people who have HPV infections will clear their infections, and even those who have dysplasia, the vast majority will clear without our intervention. So we do not screen women before the age of 21. I want to point out on the other side of the screen, this applies to all individuals with a cervix. It also is intended to focus on patients who are asymptomatic and have a normal exam. If you're having a patient who's have abnormal bleeding, pain, something that is not asymptomatic, or something abnormal on physical examination, this screening is not for those patients. Those patients might need a diagnostic test. This also is based on data that was collected in the United States, so it is applicable to our population. It does not apply to people who've had a previous high-risk lesion. It does not apply to women who have a previous DES exposure. As you remember, DES was given to women, I don't know, probably 50 years ago to decrease for nausea in pregnancy, and it caused vaginal cancers in their female offspring. And we're starting to see the people who have been exposed to this go away. I see a rare patient with exposure. And then patients who are immunocompromised may not have that same robust immune response and ability to get rid of HPV. So those patients may not fit with these guidelines. For patients aged 21 to 29, I told you that all of those patients who have had sex with someone else, the vast majority of patients, have been exposed to HPV. So testing for HPV as part of their routine screening is not as important as using that in patients who are older. So we recommend cervical cytolysis. So that's just the good old-fashioned pap smear every 3 years. Your lab may reflex to HPV testing if there is an abnormality, but that's the reasoning behind why that's recommended. For women aged 30 to 65, recommendations, there are a few recommendations. Number one, you can continue with a regular pap smear every 3 years. It's recommended that it be a liquid-based pap smear. Or you can do HPV or high-risk HPV testing every 5 years. Or you can do co-testing. This is what we use at Virginia Mason. Co-testing is high-risk HPV testing in every patient, along with cervical cytology, and that can be recommended every 5 years. If a patient does not have high-risk HPV on our reports, that's resulted as either high-risk HPV 16, high-risk HPV 18, or high-risk HPV other, their likelihood of having cervical precancer or cancer in the next 5 years is just minuscule. We all have patients where we can remember that one, and the recommendations are really what is recommended to not overtreat people. For people aged over 65, I'm going to comment on that a little bit later. There are patients who can sort of graduate from HPV testing and from screening, but it's very important that you understand what their history has been before you let them know that they don't require this screening anymore. And then people who have had a remote history of hysterectomy with removal of the cervix without a history of precancer or cancer, those people do not require screening in the future. So it does require a little bit of history taking in these people. This is a quick shot of a primary HPV screening algorithm. Again, this isn't something we use yet at Virginia Mason. I'm not sure when or if we'll adopt it. There have been some concerns about it, but in general, this is an acceptable way to test. I think what people are hoping for is if we can test for high-risk HPV, there are thoughts that maybe this could be collected in something like a urine sample and help to avoid patients having a pelvic exam. I can only imagine for you primary care providers how much time it would take to complete a pelvic exam in someone who maybe has a movement disorder or is there for 15 other things. So if in the future we're able to test for high-risk HPV, this may allow us to get our screening to more people. All right, so the 2012 guidelines, that was the last time the guidelines were updated before these. They relied on these algorithms, which people in rooms like this decided what they were, and they did it about every 5 to 10 years. So you can imagine as soon as they're published, they're out of date. I don't know how many of you guys focused or used the ASCCP website in the past, but there were 100 of these charts, and you'd figure out what the patient's pap smear result was, and then you'd figure out how they fit in this, and then you'd follow the flow chart. I had 20 of these printed out in my office, and you try and figure out where they are. It was, and again, they're probably out of date by the time you find them. The ASCCP has updated not only what the results of these algorithms show, but also has allowed us to change the risks based on patients' HPV testing. The goals of the updated guidelines have been to make sure that we're focusing on the right people, make sure we're not over-treating or over-screening certain people, again, those teens and people in their early 20s who we did way more treatment for in the past than we had to. It's also meant to reduce complexity for both patients and providers. It gives us information so we can counsel our patients what their risk may be. So if there's questions about whether or not they should include follow-up pap smears in their care, they can do that. And then it also allows for easier dissemination of updated information. This included patients, nurses, oncologists, gynecologists, cancer societies, a huge list of stakeholders to help identify and create these guidelines. The goal of the guidelines at this point is to identify a patient's CIN3 risk. So if you think back to the picture of the cervix, CIN3, cervical intraepithelial neoplasia 3, is a precancerous lesion. In many cases, there's a unidirectional arrow to cancer, even though it could be many years before that develops. The new guidelines will show a patient based on their current test, but also on their previous tests, what their risk for CIN3 is, and that can help us to figure out who would benefit from treatment and what frequency of screening may be benefit. So the way that they did this was they used multiple large prospective longitudinal US databases. So things like Kaiser, things like clinical trials, there are large New Mexico HPV PAP registries and others. And it encompassed diverse populations because we know the CIN3 prevalence is driven not only by geographic location, race, ethnicity, socioeconomic status. And so we wanted to be able to determine, based on patients' results, truly what their CIN3 risk was. This would allow us to say that patients with similar test results and screening history have largely the same risk, and it allows us again to avoid overtreating some populations and undertreating others. There are some cases, of course, where data couldn't predict risk, and then literature review or consensus data is used. I'll show you when you use the application that's available. There are many times where you'll get like expert recommendation, and that's where you can use your clinical judgment or include your local gynecologist or local gynecologic oncologist in making decisions. Okay, so they used all this data and they came up with these tables. These tables are pages and pages and pages long. This doesn't even begin to encompass all of the data. And of course, while this tells you what your Pap test might be, your result of your biopsy, what your future Pap might be, there's no way you can use this in your clinic. That is way worse than printing out those other horrible algorithms. So of course, they have figured out how we can use this in our clinics. How can we use this huge database to help us to target how we best treat our patients? So again, what we want to be able to do is take a test result and help determine what the immediate risk of high-grade cervical dysplasia is. And then know from that risk, what should we do next? Does this patient need a Pap smear in a year, 3 years, 5 years? Does this patient need a colposcopy, a test where we look at the cervix with a microscope and take biopsies? Do they need an immediate excisional procedure to prevent or diagnose their cancer? And you can see with this color chart that based on the risk, we can determine what intervention is needed. So if there's a high risk of CIN3 anticipated, so 60 to 100%, the immediate risk of CIN3, we can recommend expedited treatment, which is a cervical excision, something that can be done in office for most patients in the operating room and others. For people who have a risk of CIN3 immediately of 25 to 59, those patients may have some ability to make a decision about whether they undergo an excisional procedure or a colposcopy. And that could be based on patient preference, review of risks and benefits, their goals of care, future fertility, et cetera. It might be much easier to counsel a patient on what they should do if they can get a sense of what their real risk is. And a patient may decide, based on their desire for fertility, that 25% risk is okay for them, or another patient who isn't planning for fertility or knows someone with cervical cancer, et cetera, that might be too high a risk for them. So you can really personalize their medicine. All right, so of course we fix this with an app. There's a mobile app. It's on your iPhone or your other kind of phone. And you can download it. It does cost $10 to get the app on your phone. I use it every day. I think it's great. It's automatically updated with new guidelines, et cetera. So if you're someone who's doing women's health and screening, I highly recommend spending, instead of buying 2 lattes, getting this application to let you better treat your patients and know how to manage their Pap smears. All right, so it comes with this app. It's this top left one next to my Alaska app. So for example, if you get a 47-year-old who has a current Pap smear that's atypical squamous cells with undetermined significance, and you've tested for both HPV 16 and 18, but their prior Pap smear has been normal and their HPV is negative, you can put all that stuff in the app. So sometimes it can get overwhelming with the different pages. So I usually, because I'm old school, I'll write down their Pap history, because what it will do is it will ask you for not only their current testing, so that ask is Pap along with HPV 16 or 18 positive. It'll also ask you if they've had prior screening. So this is super helpful. Not only are we using one test, we're able to use the patient's entire Pap history to help us to determine their risk. You can imagine, based on the paper, the slide I showed you before, if someone has had 6 years of high-risk HPV infection, their risk for CIN3 is going to be higher than someone who maybe has an HPV high-risk infection today, but 3 years ago it was negative. So we're able to put in all of this data into the app. How many people have this app or have seen it before? Okay. I don't get any kickback from you guys buying the app, but I strongly recommend it. You can get it on your desktop for free. They do make you confirm you're not a robot. So if that's something you're doing once or twice a day, it probably will work for you. And you don't have to give them any money. But if it's something you're doing intermittently, again, you might not mind proving that to them every time. All right, so it gives you this, it allows you then to look at the patient's entire Pap history, and then it will give you a recommendation. And not only does it give you a recommendation, I show this to my patients, it gives them a why. Why do you recommend a colposcopy and not an excision? Well, I recommend a colposcopy because your risk of CIN3 immediately today is about 4.4%. So in this case, for example, a colposcopy is recommended. For this 47-year-old who doesn't have a prior history of HPV, but has those two high risk 16 and 18 variants of HPV, we know that those increase the risk of CIN3. So their recommendation might be different than someone who, say, had an ascus pap smear with a high-risk HPV other. They might be recommended to have another pap smear in a year. And so you're really allowing yourself to get the right treatment to the right patients. Okay, sometimes it can be difficult to figure out which scenario to pick. Am I using the result of a LEAP? Am I using the result of colposcopy? Do I just have pap smears? So it does give you a page where you can like help me decide. You put in the patient's age, and then you put in routine screening. If it's a patient who's been rarely screened, so they don't have any history, et cetera. And it can help you pick what the right boxes to choose are. These are all easily found if you look on the front page when you open the app under the Help Me Decide. So are the results from a routine screen or prior abnormal screen that didn't require a colposcopy? It'll talk you through all of this stuff because sometimes it can be a little bit mind-numbing. All right, I mentioned that we would talk about some special populations, people who need a diagnostic test or people who have bleeding or have another examination. Immunosuppressed patients are at higher risk. So I said I would talk about patients who are 65 and older. So it's very important that you ask your patients if they've had prior pap smear screening prior to saying they've reached the magical age of 65 and don't need a pap smear anymore. A lot of the tests that looked at the risk of cervical cancer included patients who had hysterectomy. And so when you take out people who have hysterectomy, you actually find that the risk of cervical cancer continues to rise up into the 80s. And if you look at the top line for Black women, it continues to rise. The risk of cervical cancer is really quite high in that age range. So you have to make sure that patients have been screened, have at least 10 years of negative screening without HPV before you say that they can graduate from pap smears. So it's not enough when people come to my clinic and they say, my doctor last year told me I didn't need pap smears anymore. I said, well, did they make sure you had 3 normal paps for the prior 10 years? And if not, I recommend that we make sure that they are someone who you can avoid doing screening for the next, 30 years or so. The CDC notes something we all see every day, and that's that systemic racism in our system can make it very difficult for some people to get access to vaccinations. It can make it very difficult for some patients to get access to screening, and that there's disparity in what our patients have access to. The CDC website and what we're working on here helps to identify where those disparities might be so we can get these screening and vaccinations to every patient. We all know that access affects cancer risk. People who are at highest risk for cervical cancer are those who are rarely or never screened. That's the highest risk factor for patients to get cervical cancer. We know that includes people of color, people of low socioeconomic status, people who are foreign born or living in the United States less than 10 years, or of course, those who don't have a usual state of health care. This screening requires routine evaluations. It requires us having people be seen, a few times over 10 years. So those people who miss those opportunities may have a higher risk. We get this data from the US Census, from the CDC, from the National Health Interview Survey, and from the CDC. So in summary, we have the tools to eliminate cervical cancer, recommendation for vaccination for both boys and girls before the age of 15, and hopefully we can get up to 90%. We have an opportunity there. We screen with pap smears with also HPV testing, and we can help to identify those people who have lapsed, maybe because of COVID or another reason, who are not up to date. We can also support public health measures to improve access and education and consider advocating for policies that address disparities. You can write letters and find those things on your social media. And then of course, our politicians are the people who help to put these things in place. And so it's important we vote for people who have our patients' health in mind. Thank you. If you have other gynecologic oncology questions, please don't hesitate to reach out. Have the opportunity.
Thanks so much for the opportunity to talk about hereditary cancer syndromes and gynecologic malignancies today. My name is Allison Barrie. I am the other gynecologic oncologist at Virginia Mason, and I'm happy to be here. I have no disclosures, so similar to Amy, the things that I will be recommending today, I don't get any kickbacks, but I do think they are important. And so just a brief overview, we're going to cover this in about 20 minutes. It's going to be great. And so what I'd like to do is review ovarian and endometrial cancer in general, and then I'd really like to dive into hereditary breast and ovarian cancer syndromes. Who do we test? How do we screen? And how can we reduce their risk for cancer in the future? Additionally, we'll be discussing Lynch syndrome, particularly in the context of gynecologic cancers. Who do we test? How do we screen? And again, risk-reducing measures that we can take to help prevent cancers in these women. And then finally, my favorite part of the talk, and we'll get there if we get there, advances in cancer treatment in patients with genetic mutations, because we're really finding some exciting stuff when we're studying these women and specific treatments that we can give them when they are diagnosed with cancer. So ovarian, fallopian tube, primary peritoneal cancer, as you all know, these entities, while technically these cancers may start at different sites, they're considered kind of one and the same. Approximately 1 in 78 women will develop these cancers in their lifetime. In 2023, according to the American Cancer Association, approximately 19,710 patients will receive a new diagnosis of ovarian cancer, and approximately 13,000 patients will die from ovarian cancer. So those stats are not great. 5-year overall survival for patients with advanced disease is 30%. I think it's important to note that the vast majority of patients that we diagnose with ovarian cancer are diagnosed with advanced disease. So these statistics remain quite humbling. Approximately 80% of patients with advanced disease will have a recurrence at 5 years. So the vast majority of these women are recurring, and when their cancer comes back, it is not curable. So we treat it as if it is a chronic disease and go from there. So again, these are cancers that start in the ovary, the fallopian tube, or the lining of the abdominal cavity, the peritoneum. And again, they often present at an advanced stage, as this is when patients develop symptoms once things have spread, the horse has left the barn. The symptoms that we think about most commonly in patients with advanced ovarian cancer include bloating, urinary urgency and frequency, early satiety, and pelvic pain. And I do not need to share with this room of excellent healthcare providers that those are pretty nondescript symptoms, right? People come in with that every day. And so it's a really hard thing to diagnose and to find early. So a brief overview of ovarian cancer stages. Stage 1 is where cancer is found in one or both ovaries. It's pretty hard to diagnose it at this stage, but we do our best. Stage 2, cancer has spread to other areas of the pelvis. So that includes the uterus, can also include the rectosigmoid colon, the peritoneum within the pelvis itself. Stage 3 is where cancerous cells have spread outside the pelvis. So in general, we find these in the omentum, that fatty drape that covers the transverse colon. Can also spread to the peritoneum in the upper abdomen. We often see implants along the diaphragm or in a space called Morrison's pouch, kind of below their right kidney. Can also spread to small bowel mesentery, places like that. And then stage 4 is when the cancer has essentially spread to the lungs or the liver. And here's the problem, right? Most of these patients we diagnose at stage 3 because that's when they develop symptoms. And it is an incredibly hard cancer to cure when it's at stage 3. So just a note, we have different types of ovarian cancers. And for the purposes of this talk today, we'll really be focusing on epithelial ovarian cancer because that tends to be the cancer that's associated with hereditary syndromes. There are 4 different cell types within that category. High-grade serous is the most common type of ovarian cancer that we see, but also we have endometrioid ovarian cancer, clear cell, and carcinosarcoma. Less common ovarian cancers that I will not be discussing today include stromal tumors and germ cell tumors. So how do we treat ovarian cancer? So primary treatment consists of a combination of systemic chemotherapy and surgery. And this is something that Amy and I do every day. We think about kind of the order of treatment. Where should we start? And really, the decision-making comes from, is the cancer amenable to complete surgical resection? And then where does chemotherapy fit into that? So you may start with a debulking surgery, followed by 6 cycles of carboplatin and Taxol. you may decide based on CT scan that there are implants in the liver, the lung, those are not resectable. And so you start with chemotherapy first. The idea being you get the cancer to a state where it is amenable to surgery. Usually that's after 3 or 4 cycles, and then you follow up with 2 or 3 more cycles of chemotherapy. But that's kind of the thought process when we're looking at a new diagnosis of cancer. And this may or may not be followed by maintenance therapies, depending on the stage and patient factors. And we'll talk about that a little bit at the end of the talk, because we actually think that patients with hereditary breast and ovarian cancer syndromes may benefit very significantly from maintenance therapy. So how does this fit into hereditary cancer syndromes? Well, approximately 20 to 25% of patients who develop ovarian cancer have a genetic mutation that predisposes them to ovarian cancer. And less than 1% of the general population have these mutations. So this is actually a really important thing for us to note. Now, when we think about what particular genes put people at risk for breast and ovarian cancer syndromes, here's the list that we have identified and are pretty confident are associated with either. Now, the ones with the asterisks, so BRCA1 and 2, BRIP1 mutations, mutations in the mismatch repair deficiency pathway, so MLH1, PMS2, MSH2, MSH6, and EBCAM. Those are also associated with ovarian cancer. And finally, RAD51C and D increase people's risks for developing ovarian cancer as they age. And so those are the genes that we think about when we're particularly considering gynecologic malignancies in this setting. So testing for individuals for high penetrance breast and ovarian cancer genes puts them at increased risk for disease. We want to know about them, right? Because, and we'll get to this part of the talk, we have some ways to intervene. If we know someone has a BRCA1 or 2 mutation, we can start talking about interventions that may reduce their risk or eliminate their risk for developing gynecologic malignancy in the future. And so the question always becomes, who do we test? So family and medical history screening is really, really important. So what we really want to know is a first or second degree relative history of any cancer. And so you may find when you're asking your patients about family history, they say, oh, no one in my family has cancer, not my parents or my siblings, but we want to know about grandparents, aunts, uncles, grandchildren, nieces, nephews, because you may start to establish a pattern that makes you start to think, hey, I think something might be going on here. There might be some sort of hereditary syndrome. Another important clarification, we want to know what side it's happening on, right? Maternal versus paternal. We definitely want to know if people have Ashkenazi Jewish ancestry. That puts them at increased risk for hereditary syndromes. And then for each cancer case, it's important to establish an age at diagnosis in a primary disease site. I will tell you, I think this is one of the harder things to do, just because a lot of patients don't actually know what type of cancers their family members had. Sometimes patients were diagnosed with an advanced cancer and then they passed away and no one did any testing at all. And so you kind of have to extrapolate a bit to figure out where your patient falls into which category. And so that might take some teasing out, which I know we can all do because we're excellent historians. So these are kind of some general guidelines for who you should consider referring to genetics counselors for testing for hereditary breast and ovarian cancer syndrome. And I'm going to show you the way to find specific guidelines. So through NCCN is the best place, I think, where we can find these guidelines. They're updated annually. But in general, if patients have a cancer diagnosed at an unusually young age or less than 50 years old for breast, ovarian, or colon cancer, that's someone that should be on our radar for referring to genetic testing. If a patient has several primary cancers in themselves, so if your patient was diagnosed with breast cancer and then ovarian cancer, that should be a sign that they should be sent for genetic testing. Several close blood relatives with the same type of cancer, an unusual presentation of a specific type of cancer. So I won't go into this today, but breast cancer in a male, that's unusual, and they should be sent for genetic testing. Specific benign conditions associated with cancer syndromes, patients with triple negative breast cancer, and then for us, particularly in GYN oncology, any patient with a history of ovarian cancer, fallopian tube, or peritoneal cancer should be referred for testing, and any patient with colorectal cancer or endometrial cancer with a mismatch repair deficiency. So I refer to these guidelines a lot, if not every day, and I think it's a great resource for everyone to have. These are free. You can sign up for the NCCN and find these guidelines on their website. Sometimes they're a little detailed, but you can find what you need based on the table of contents and kind of get to where you need to go. But if you open up the guidelines, here's a really nice table of contents, and you can go to the hereditary testing criteria and look at each category that you're interested in and see if people meet the criteria. So for instance, for high penetrance ovarian cancer susceptibility genes, you can click on that and see who should be tested, what the criteria are, and go from there. So in general testing criteria, and then you can click for specific disease sites, which is really nice. And then if you, and then here's the detailed criteria. So this is why I don't go into this in this talk anymore. I used to stand up here and go through each criteria. You could see everyone starting to fall asleep. But here we go, right? So here's your personal history of cancer. Here's the family history of cancer. And here's your criteria for who should be tested and why. And so it's a pretty easy thing to get through and sort out. I think one of the most important things that I can share with you today, I think that a lot of people maybe don't have on their radar, is that we know that people with a diagnosis of ovarian cancer should be tested for hereditary breast and ovarian cancer syndrome. And often that happens in the oncology clinic, right? Oncologists are thinking about that as part of their cancer diagnosis and treatment. But anyone with a family history of ovarian cancer and a first or second degree relative should also be tested for hereditary breast and ovarian cancer syndrome. And I get these patients in my clinic all the time for other things, for abnormal PAPs, for abnormal uterine bleeding, and I catch a lot of these. And so I think this is an important thing to know, that these people are technically part of our testing criteria as well. This also includes first degree relatives with pancreatic cancer. Just a note, so you probably have a lot of patients in your practice who were tested for genetic syndromes 10, 15 years ago, but our panel testing has really expanded. So historically, we tested for BRCA1 and 2 because those were the only genes we knew about, or those were the only genes that we had commercial testing for. When I send my patients to a genetic counselor today, they often get an expanded 72 gene panel. And so I think it's really important to reassess if your patient has a high risk for hereditary syndrome and they've been tested 15 years ago, you may want to talk with them about whether or not that testing should be updated and if they should head to the genetic counselor office to talk about that. I think multi-gene panel testing is a great tool. All great tools come with disadvantages as well. So the advantage of us doing multi-gene testing now is we're casting a wider net. The more we discover about genes that may impact breast and ovarian cancer risk, the more gene panels expand to include testing for these mutations. But the disadvantage is that then we get a lot of information that we don't know what to do with. We have an increased risk for finding variants of unknown significance. I will tell you that when you find a variant of unknown significance, the vast majority of them, as we gain more information, end up being reclassified as benign or non-pathologic. But this is only one of the reasons why with genetic testing, it's really important to have patients meet with genetic counselors, because they can really talk with them about variants of unknown significance and how we manage them once they come up. So once you've diagnosed a patient with hereditary breast and ovarian cancer syndrome, what do we do? Can we screen for ovarian cancer? And if we go back to medical school, to our statistics class in college, we know that good screening tests need to have a few criteria. They first need to be inexpensive. They secondly need to be easy to administer. Thirdly, they should cause minimal discomfort to your patient. Fourth, they should be reliable or consistent. And fifth, they should be valid. So they should have a high sensitivity and a high specificity. And we just don't have that for ovarian cancer. I feel like when I started on my journey in GYN oncology, we were really hopeful that, gosh, if we gave everyone a pelvic ultrasound once a year, and we did a CA-125 once a year in everybody, we will certainly detect more ovarian cancer and we're gonna find things early. And that's just not true. What we actually find is when we do those interventions, we're doing surgery on people who don't need it. So we find benign cysts and growths, and we're taking out ovaries, and it's benign things that we would have never found otherwise that have no cancer potential whatsoever. And then the other thing that we find is that, you guys know this, I'm sure, CA-125 levels are really problematic. they can be raised for all kinds of reasons. So your diabetic patient could have an elevated CA-125 because it's an inflammatory marker. Your patient who is currently menstruating will have an elevated CA-125 today, but not tomorrow. And so these tests come with all kinds of issues that have ultimately led to us saying, we don't really know the utility of these tests, even in patients who have a high risk for ovarian cancer. So you will find actually that in the NCCN guidelines, this is actually dropped out. It's no longer recommended even for your BRCA1 and 2 patients. I will tell you in real practice, what is still happening is that you just have to have a really thoughtful discussion with your patients. And they should just know that if we do this test, we may have elevations that are not related to cancer. You may have to come and see one of the oncologists to sort it out. We may end up doing unnecessary surgery. And there's no data that shows it helps anyone to live better or longer. And I will tell you, I have this conversation every day. And I still have patients who elect to do it. And so we're in this gray zone, I think, with this testing, particularly because historically we've always offered it. The good part, when we diagnose patients with hereditary breast and ovarian cancer syndrome, we can do things to prevent cancer from developing. And so for us with ovarian cancer, we think about removing the fallopian tubes and ovaries. So risk-reducing bilateral salpingo oophorectomy essentially eliminates their risk for ovarian and fallopian tube cancers. And so what we want to do is perform these surgeries at a time before they're at elevated risk for developing cancer, but kind of as long as we can, because we have to remember we're inducing surgical menopause, and that also comes with health risks. So for BRCA1 patients, they tend to develop their ovarian cancers in their, the risk starts to increase in their mid-40s. So we usually recommend removal of tubes and ovaries after completion of childbearing and after the age of 35 to 40 years old. BRCA2 patients develop their ovarian cancers later. So their risk starts to increase in around the age of 50. So you can actually delay their oophorectomy a little bit longer. So I'm usually talking to these patients about risk-reducing salpingo oophorectomy in age 40 to 45. And then also for the other genes, we have data about when their onset of risk starts to increase. And we think it's also later, similar to BRCA2. So we recommend removal of tubes and ovaries for patients with BRIP1 mutations, patients with RAD51C and D mutations around age 45 to 50 years old. In some of these patients, we also talk about hysterectomy at the same time. I would say 95% of my patients that I talk about risk-reducing bilateral salpingo oophorectomy ask me, well, what about my uterus too? You're there anyways. I'm like, that's true. And hysterectomy is a bigger surgery, right? And so we should probably have a good reason to do it if we're thinking about it. There are a couple of good reasons to offer it in our hereditary cancer syndrome patients. There is some data that came out, I think it was in 2018, that is suggestive that a very rare endometrial cancer, it's called uterine serous carcinoma, may be increased in BRCA1 patients. And you can hear the language that I'm using, right? Maybe small increase. It's not entirely clear, but the suggestion is enough that we've started to talk about our patients about this risk and certainly offer hysterectomy in BRCA1 patients if that seems like something that they feel will be beneficial for them because of this potential risk. The problem with uterine serous carcinoma is it's very similar to ovarian cancer, so it's difficult to treat. And so I think that's why we're so conservative about this recommendation. The other things to think about, if we're inducing surgical menopause, we want to give those patients back hormones. And if you do a hysterectomy at the time of removal of fallopian tubes and ovaries, you can simplify their hormone replacement therapy regimen. So we know that patients need estrogen and progesterone for hormone replacement therapy regimens if they have a uterus, because the estrogen will stimulate their lining and increase their risk for endometrial cancer. The progesterone therapy is protective. It helps eliminate or reduce that risk. So if you do a hysterectomy at the time of risk-reducing salpingo oophorectomy, they can just have an estrogen patch and not have to worry about the progesterone. So we have a long discussion about that as well. Also, people have all kinds of other things going on at the time of their risk-reducing salpingo oophorectomy, fibroids, pelvic pain, heavy periods. And so those are patients that sometimes we consider hysterectomy in as well. Some people talk about reducing endometrial cancer risk for patients taking tamoxifen. I think that's a discussion to have with your patient. I don't think that is a clear-cut recommendation at this point. So we do these all the time. I think the most important thing to take away from this is that we do them through 3 small incisions. So this is a minimally invasive surgery. Patients go home the same day. Recovery time is 2 weeks. So in general, it's pretty straightforward. And this is what a pelvis looks like at the time of risk-reducing salpingo-oophorectomy. This is a completely normal pelvis. So uterus in the midline, fallopian tubes hanging over your ovaries laterally. And as a surgeon, I can tell you this surgery in general is a chip shot. It's a pretty straightforward thing. Like I said, patients recover really nicely. Amy and I probably do 3 or 4 of these a week, a month, and it's hugely beneficial for these patients. Now, this is a pelvis with advanced ovarian cancer. This is not a chip shot. This is hard. And patients stay in the hospital for days, weeks, recovering from these large cancer surgeries. And so I show this picture just to really highlight what an opportunity it is to be able to find these patients, diagnose them, and have them never develop cancer in their lifetime. So I only have 5 minutes left. We certainly don't have time to talk about endometrial cancer in 5 minutes. So I'm going to skip to the end and talk to you a little bit about why, as oncologists, we also are super interested in finding hereditary breast and ovarian cancer syndromes. So historically, and I spoke about this, we have treated ovarian cancer patients with a platinum doublet, carboplatin and Taxol, and some surgery at some interval, depending on how they present. And we knew that the vast majority of those patients recur at 5 years. When they recur, we can no longer cure their cancer. And it's devastating. And for years, we had the needle didn't move. That was what we did. And we all chugged along. And we just hoped that eventually the science would catch up and give us an opportunity to help prolong these patients' lives. And we have it. So SOLO-1 is a randomized control trial. We now have 7-year survival data for these women. This is a survival curve that I love because I'm an oncologist and I love survival curves. But this is fantastic. Women are living longer when they have a BRCA1 or 2 mutation or a BRCA1 or 2 like mutation, and they're given PARP inhibitor therapy after their chemotherapy and surgery. And so we have moved the needle vastly in these women. You can see there's a 67% survival rate compared to 46% in the placebo group. This is a big deal. This is a pill that patients take twice a day for 2 years after their therapy. It is not completely without risk, but it certainly has a lot of benefit. And so when we find these women, if we can't prevent their cancers, we now have therapies to help them live better and longer. So just a way for us to really keep moving the needle in cancer care. And I show this slide because before 2014, there were like no new approvals in the ovarian cancer space for years. And now we have several because of PARP inhibitors. And so we've really made a breakthrough, I think, in helping these patients to manage their disease. And like I said, to live better and longer. So in summary, patients are at risk for hereditary breast and ovarian cancer syndrome. We didn't talk about Lynch syndrome today. These syndromes increase the risk for patients' ovarian cancer diagnosis. But when we diagnose them, there's an opportunity for cancer prevention with risk-reducing surgery. And we can find these things just by taking a thorough family history. We should consider risk-reducing gynecologic surgery in women with these mutations. And if we don't catch them early or they don't have a family history suggestive of this, we're starting to have emerging therapies that are targeting mutations that are demonstrating really quite promising results for us in gynecologic cancers. Thanks for your time today. I really appreciate it. I'm happy to answer any questions about hereditary cancers, and then Amy, if there are any, I could also answer Amy's cervical, you know.
So my name is Alex. I was just curious, people who don't know their family history, how do you counsel them whether or not to do the testing?
Yeah, it's a tricky one, right? And I think for the most part, they don't get testing because we aren't universally screening everyone at this juncture. Do I think that will change in 10, 20 years? Certainly. I think we'll have to figure out what we do with that other side of the coin with multi-panel testing, right? Where we find this information that we don't know what to do with. If we can somehow narrow our perspective on all of that and figure out a way to interpret results a bit better, I think we might start expanding testing to broader populations.
Thank you. I have a pretty loud voice, but I know you need it for the recording. Jennifer and Local Family Practice. And thank you very much, both Dr. Bees, for your great talks. I was wondering if you could comment on the 2017 U.S. Preventive Task Force recommendation that pelvic exams are no longer apparently helpful. And having been doing this for 30 years, I was really kind of taken aback a little bit by that.
Yeah.
And I almost find any excuse to still go, so, I mean, you must be having some kind of pelvic pain. I mean,
Yeah.
you can find a lot doing a pelvic exam. So I
Right.
was just really curious to hear your comments on that. Thank you.
Yeah, this is so interesting. Because I agree, right? We have this recommendation, and recommendations are important. But then we also have all of this experience. We've all found something on pelvic exam that we never would have found otherwise, right? Or until it had progressed to something that was very concerning. And so I actually see this a lot in my practice. I'm curious what Dr. Brockmeyer's thoughts are too. But essentially, I really use a shared decision-making model with my patients in this case. So I tell them if they are, so for instance, they're done with cervical cancer screening or they've had a hysterectomy. Patients love that. They're like, fantastic, I never have to do this again. This is great. And I say, yes, there are guidelines that state that there's no scientific data that shows that we find anything earlier on pelvic exam. And sometimes, you know, in our personal experience, some practitioners think it's helpful. And I kind of put it in the patient's court. And I find a lot of patients elect to come in once a year and get a pelvic exam. I will also say on the flip side, you're also giving an opportunity for patients who have experienced trauma, for patients who have experienced other reasons why pelvic exams are really challenging for them. You can tell them that there's no science that an annual pelvic exam every year, once they're done with screening, once they've had a hysterectomy, is beneficial. And so I think we can give power to our patients with that data and go from there. And that's how I approach it personally. And I don't know if Dr. Brockmeyer does anything different.
Totally agree that shared decision making is really important. The thing that I think is really interesting about that recommendation is it's for asymptomatic women.
Yes.
And so that means you have to ask, do you have change in your urinary frequency? Are you bloated? Do you have pelvic heaviness? Do you have any bleeding? And that's a really hard thing to do in a short visit where you're also assessing their diabetes and, you know, their movement disorder. So I think in someone who is truly asymptomatic, that we don't have data to say it's beneficial. And I would exactly say what Dr. Barrie said, but it sort of doesn't count if you don't ask or patients don't tell you that they've had a change in their pelvic symptomology.
Yeah.
Hello. Yes, I'm a physician assistant, Mary Lyons, and I work at Urology Clinic. We see, I kind of have two questions. We see a lot of women with frequency and urgency, also hematuria, as well as irritable or interstitial cystitis and chronic pelvic pain.
Yeah.
When we have cleared urologically reason for hematuria, I'm often thinking about gynecological reasons. And is there something that I should be triggered by to automatically send them to you guys?
Yeah, I would think that if you haven't found a urologic reason for any of those symptoms, that you should send them to a gynecologist because, and you know this really well, our pathologies overlap in so many ways. Have I diagnosed endometrial cancer in someone who presented with hematuria because it was actually postmenopausal bleeding? Of course. So I think if you haven't found an explanation for their symptoms, absolutely, they should get themselves to the nearest gynecologist. Yeah.
Okay, thank you. My second question is in a female who's the older recommendation for the HPV vaccine now. What if they've previously had a positive HPV, and does that mean why bother?
That's a great question. So
We actually think that there could be some secondary prevention. So sometimes I'll see patients in my clinic with an abnormal pap smear who maybe hasn't completed their HPV vaccination series, and I'll have them complete it. So that might be another opportunity to get people vaccinated who may have been in that donut hole, who were too old to get it when it was recommended. So I don't see a downside to getting a vaccine if someone hasn't completed it, no matter what their pap smear results are.
agreed. And then the other thing too is that they may have one strain of HPV, but the HPV vaccine it's a 9-valent. And so if they get infected with a different, I think it's a great idea.
Dr. Chua here, infectious disease. I have two questions. I have patients that send to me for recurrent UTI, and a lot of the patients are not examined gynecologically. And I think it's important for us to check the physical exam, because I found cysts and other things that they just give antibiotics and antibiotics. So I said, I need to examine gynecologically on this, because I found so many things.
Yeah.
So I know it's a pain to do that, but I do it if they come recurrent. The other question is, what's your experience? Because I have so many recurrent UTI, they have recurrent dysuria, and they have atrophic vaginitis, but some of them don't respond to the cream. So I give them petroleum jelly and they feel fine. So what's your experience on this? I don't see it a lot in the literature, but a lot of them think he said, oh, Dr. Chua, this has been bothering me for years and nobody can solve it, but you solve it by applying petroleum jelly on the labia area. So have you experienced this?
I haven't. I will tell you that dysuria is very interesting, because we often think about recurrent UTIs. We often think atrophic vaginitis. Please put your patients on vaginal estrogen if they have recurrent UTIs. There's excellent data for it. Thank you for mentioning that. But I think the other thing that we forget about are vulvar conditions. So there are so many vulvar conditions, and that is out of the scope of today and certainly out of the scope of my practice. There are people who specialize in this, which is fantastic. So I wonder if there are other conditions going on where they warrant an exam by a gynecologist, a biopsy, a skin biopsy, because some of these women have lichen sclerosis, which we treat with clobetasol, and they're at increased risk for vulvar cancers. Some of them have lichen simplex chronicus, which is chronic vulvar itching, and we need to talk about vulvar hygiene. So I would say get those folks to a gynecologist. I think that makes a lot of sense.
Yeah.
If you can. I know the resources are challenging.
Yes, and
sometimes.
I think the exam is important. Examine the patient, don't just give antibiotics. I
Thank
see a lot of patients. that come
Agreed.
in.
That is not an asymptomatic patient. I agree with you. And thank you for performing those as an infectious disease specialist. All right.
I can just talk to you right here. So, hi, my name is Naomi, and I have a question about ectropia and PAPS. So, I've been challenged by getting a good sample due to the ectropia. Any tips for how to solve that?
So we're talking about extropion in pap smears. So my first question is, are you testing for both HPV and cytology? So your HPV test should still be accurate. Sometimes if you're seeing a lesion on the cervix and you're 100% sure it's an ectropion, carry on. Do your pap smear or HPV test and you're good. If you're not sure, then that really doesn't fit asymptomatic. They may not be okay for just screening and a biopsy to prove what you're worried about may be the right.
Yeah, it's true. I have had patients referred to me for cervical cancers and it's an ectropion, and that's fine. I'm happy to look at that. I've had patients who've been referred to me with an ectropion and it's cervical cancer. It's not always clear, especially if you're not looking at 16 abnormal cervices a day, right? I mean, so we're happy to, if there's ever a question, it's no problem. for us to help out.
What's the oldest person you've seen with an ectropia?
Oh, gosh, I actually don't even know. So I will be honest with you, his question was, what's the oldest person I've seen with an ectropion? So if you think about it, right, pathophysiologically, as people age, their transformation zone recedes into their endocervical canal. And I don't do a lot of like asymptomatic routine well woman exams as an oncologist. So I don't know. What about you, Amy? Anything? Yeah, no idea. But if you see one in a 65-year-old, you should have a heightened awareness of, hey, what's going on here?
If they're 30, 40, 50, I would say maybe, but get
Yeah.
you to an oncologist. Or a gynecologist who can examine them. There's no reason to freak someone out if you're really just not sure and need to double
Yeah.
check.
Yeah.
It is perfectly fine to call and ask someone who does it more frequently to take a look and get confirmation. No harm.
I have a question from a virtual attendee. What if a patient is 65 and has normal PAP, but has not had a PAP in the past 10 plus years? Could she stop getting PAPs, or does she need 10 years of negative PAP until she's 75?
Oh, what do you think, Amy? That's a great question.
They don't meet the criteria to stop. So I would repeat a PAP with HPV and show that they don't have HPV or abnormal screening. And then I'd have a shared decision-making discussion with them. If it's someone who, they have to lug their oxygen with them and they have horrible coronary artery disease and getting them to the table and they have other things that are limiting their overall length and quality of life, we could probably have a discussion that that's not something that's going to help them. If they're, bounding into my office and they have 30 years of healthy life ahead of them and they haven't met the criteria, then it sure would be a silly thing to miss something that would be preventable that could affect their length and quality of life.
I'd like to thank both doctors for their excellent lectures, and we'll take a 10-minute break now so we can stay on schedule.